Thank you everyone for coming along today. I was really delighted when Amanda said that oral health was chosen as a subject for a joint seminar. And I thought this postcard really represents how the relationship between oral health and general health has typically been viewed. That for some reason the mouth has been completely disconnected from the body. And it's only in recent decades that oral health has been seen as an essential and inseparable component of general health. And this is the direction that we're now starting to take. So I also think this postcard represents that direction, and that we need to reassemble the snowman and put the head back on the body. And I see this as an opportunity to take a step in that direction, and it's certainly a direction that the Ministry of Health with the New Zealand Oral Health Strategy is taking, and also recommendations from the World Health Organization. So what are we going to do today? I'm going to try and condense a year's worth of learning into 5 minutes for Dentistry 101, just to kind of give everyone up to speed on what we're talking about, and then provide you with a national view in terms of the prevalence of dental caries, and look at some of the public health solutions that we might apply to the problems that we have. My colleague Kathy is then going to give you a view from the chair side, what it looks like to be a dentist in the hospital system, and just what her day looks like. And then we'll get Emmeline here. She's from the New Zealand Fluoride Information Service, and she's going to talk to you about the challenges of working in the fluoridation area and community water fluoridation. So it's always good to start with the definition, isn't it? What is oral health? The first definition has probably got a bit of a familiar ring to it. It's a state of complete physical, mental and social well-being, and not merely the absence of disease. But Robbie Beaglehole goes on to actually expound the different types of oral disease that there is, because we almost probably always instantly think about tooth decay, but it is certainly much more than that. It involves oral and throat cancers, gum disease, chronic pain, oral tissue lesions, birth defects and other diseases and disorders that affect the head and neck. I quite like the second one even better actually, from the World Health Organization. A natural, functional, acceptable dentition which enables an individual to eat, speak and socialise without discomfort, pain or embarrassment for a lifetime, and which contributes to general well-being. And I think if you were to ask anyone out in the street, this would probably encapsulate what they would think of as oral health and the impact that it has on their quality of life, rather than in terms of disease. But no doubt everyone is very familiar with the physical and psychological aspects of the consequences of oral disease, and we've probably a fair proportion of people in this room have come into contact with it at some stage. But the consequences of oral disease are actually far more wider than that. It influences how people enjoy life, how they look, how they speak, how they chew, how they taste their food, as well as their feelings of social well-being. People, and especially children, experience eating and sleeping disorders, which then affects nutrition, growth, weight gain, and also the ability to learn. Dental caries results in lost days at school, time off work, and therefore lost productivity, and it's expensive to treat. And there's a high risk of hospitalisation, particularly with children, and that has its associated risks and costs. So oral health problems are important public health problems because of their prevalence, the impact that they have on the individuals, and the high cost of their treatment. One of the most important contributions we can make with oral health actually is to the quality of life. Just looking at the costs associated with oral health, it's actually the fourth most expensive disease to treat. And in 2008, the total system cost was around $1 billion. The majority of that was privately funded because of the way that our oral health system is set up. And the majority of the public expenditure for that comes from the school dental service. Just to give you an idea and to kind of put it into context, the spending on obesity-related, the public expenditure for that is roughly the same. From the Oral Health Survey in 2009, children aged 2 to 17 years, 13% of those children took on average 2.5 days off a year to deal with their oral health problems. And of course you can see that the parents took the equivalent time off. For adults, about 1 in 10 adults will take approximately 2 days a year off to attend to their dental problems. So just even from a cost perspective, the consequences are reasonably substantial. So I'm just really going to be talking about dental caries, tooth decay today, because that's what affects children the most. So what is dental caries? It's a bacterial infection, it's multifactorial, it's preventable, and it's a chronic disease which occurs over time. And once it's established, its impacts are irreversible, and the impacts accumulate over the lifetime. As we know, it's moderated by diet, and it's non-discriminatory. Anyone can get dental caries, but some groups in the population are at greater risk than others, and we'll talk about that in a moment. So if you look at the diagram on the bottom here, this is the process of dental caries. So we have this nice bacteria that sits in the sticky plaque on your teeth, and we feed it sugar, and it produces acid, which eventually dissolves the enamel on the tooth, and over time creates a cavity in the tooth. So we start out with something that looks like this. It moves on and progresses through time to something like that if it's left untreated. And so I think you can probably see from these pictures that the impact that not only has physically, but also certainly on wellbeing and quality of life. So some of the risk factors are fairly obvious, I would think. Oral hygiene, obviously we need to keep the teeth clean and remove the bacteria, that's really important. And of course diet. Not so much the amount of sugar that's consumed, but the frequency at which it's consumed, because every time you eat something, the bacteria is getting fed and the acid's getting produced. Ethnicity and socioeconomic deprivation, it's a chronic disease, and there are always risk factors, unfortunately. Low socioeconomic status is a risk factor for oral disease in childhood, and it's not reversed with social mobility going into adulthood either. Living in a non-fluoridated area is high risk. And we now know from numerous studies, including the Dunedin multidisciplinary study, which not, of course, only examines people over their lifetime, but we now have intergenerational data to show that mothers can pass on oral bacteria to their children, and that maternal oral health is a predictor of child oral health when the child is young, but also when that child becomes an adult. So 30 years later, there is an association between the state of oral health in an adult and their mother at the time when they were born. And that's for both gum disease and tooth decay. And of course, we also know that parental attitudes and experiences also impact upon children in childhood. The other four here are probably more risk factors for adult oral health, although there is evidence to show that secondhand smoke increases the risk of childhood caries. But tobacco is certainly one of the main risk factors for gum disease in adults, and of course oral cancer, along with alcohol. Medications and radiotherapy, the side effects of those is usually a dry mouth and reduction in saliva flow, which is protective for dental caries. So why children? It's kind of an odd question probably to ask, but it's important to consider. And the New Zealand Oral Health Strategy certainly recognises children as a priority group, saying that good oral health for all for life starts with promoting oral health for the youngest and most vulnerable members of our society. And we must remember too that children have the right to health, and that includes oral health. Child health is the basis of adult health, and that's true for oral health as well. Tooth decay in childhood is predictive of tooth decay in adulthood. And dental treatment in childhood is a predictor of dental anxiety in adults. About 2 in 5 adults report that their dental experiences before the age of 10 are the reason for their dental anxiety. And that, of course, then impacts on dental attendances and regular dental care. We also know that we, as with any other behaviour patterns, usually established early in life, and that includes regular attendance as well as oral hygiene practices. And we also have to think about the cost of treatment. The future oral health care demands and needs it's going to be huge in the future. We now know from the 2009 survey that almost all New Zealanders under the age of 55 have at least one tooth, and probably several have many more than that. But if we think about, 20 years from now when those people are 75, older adults are a high caries risk group, and these people in this age group, particularly from 40 to 60, have had a high amount of treatment and require considerable maintenance on their oral health. So how much is out there? Dental caries is the most common childhood disease, and it's also the most common disease in adults, actually. 60 to 90% of the children worldwide have dental caries. We have several ways of measuring dental caries and the impacts and the severity of it, and one way that is very common is the percentage or the proportion of the population that are caries-free. And that means the proportion of the population who have had no caries experience. So their teeth are all sound, they've had no fillings, they've had no decay, no teeth out. And we know from the New Zealand Oral Health Survey that half of New Zealand children are caries-free. But that also means that half of them have caries, and it's a substantial proportion. We know that there have been improvements in oral health in recent decades, and that the proportion who are now caries-free has doubled in about 20 years' time, in that 20-year period. One other index that we use is called the DMFT. It's the Decayed, Missing and Filled Teeth Index, and that's a summation of all the teeth that have been affected and impacted by dental caries. So that's the sum of the teeth that have been decayed, missing and filled due to caries. The uppercase DMFT is for permanent teeth, so that's the adult teeth, and the lowercase DMFT is for children's primary teeth. And we can see from the Oral Health Survey that the DMFT for 12 to 13-year-olds has halved, which is great, but we're not doing as well as some of the countries that we compare ourselves to. And I was reading the other day that Sweden report the DFT because there are no children in Sweden who have teeth missing due to caries. So despite our improvements, there are still disparities within certain population groups, and that's by ethnicity and deprivation, of course. And what does that look like? This table is taken from the Oral Health Survey 2009, and I just really want to draw your attention to the ethnic group part of the table here. This is the prevalence of being caries-free in all children aged 2 to 17, and we can see that Māori and Pacific children are significantly less likely to be caries-free than non-Māori, non-Pacific children. And also, if we look down on the deprivation at the bottom of the table, those who live in the most deprived neighbourhoods are less likely to be caries-free, although that wasn't a significant finding, and there are certain reasons for that. But we know that children aged 2 to 11 have fewer sound primary teeth, and they are 6 times more likely to have primary teeth missing due to decay, and significantly more likely to have more teeth missing due to decay. This is another table from the survey that's looking at untreated coronal decay. So this is the actual active decay that's currently present in a mouth when it's examined, and is usually an indication of accessing services. And we can see here that Māori are twice as likely to have 1 or more teeth with untreated coronal decay. Pacific children were 1.5 times, although that wasn't significant. And if we look at, in terms of deprivation, those children who are most deprived are 1.5 times as likely to have untreated coronal decay at any one time. So there are, significant disparities. I mentioned about hospital admissions earlier and the risk involved with that. And this table's taken from Liz Craig's Health Status of Children and Young People, and shows the arranged admissions and waiting list admissions for children aged 0 to 14. And we can see here that dental procedures top the list for the waiting list admissions. 1 in 5 children on a waiting list are waiting for a dental procedure. So, it's a really important cause of avoidable morbidity and preventable hospital admission. And the majority of that will be for dental caries and dental abscesses. And Kathy will talk a little bit more about that. Be mostly restorations and probably extractions, a fair few, under general anaesthesia. We can see from this graph here taken from the same document, that the children who are most affected by this are aged 2 to 9, but particularly the 4 and 5-year-olds. It's probably because they have all their primary teeth by that age, and will clearly need to have some work done on that. And I know this slide's a bit messy, but it shows a couple of really interesting things. This is hospital admissions by ethnicity. You can also see the difference in the age grouping there, but what I want to show you is that Māori and Pacific are 2.5 and 3 times more likely to be admitted to hospital for dental caries than European children. And we can also see that the gradient, particularly on the data for Māori, is quite steep and continuing to rise, whereas for European children it's tended to flatten out and remain pretty stable over that time period. And finally, this is a table for hospital admissions by deprivation, and again we can see the gradient that children, particularly the young children under age of 4, are 3.5 times more likely to be admitted to hospital for dental caries than those children coming from an area of low deprivation. And that works for children of all age, slightly less than the older age group. So what can we do about it? Well, we can treat it, and we know that that's really expensive, and we know that that has an impact on quality of life, and we know that the best thing that we can do for oral health is actually to improve quality of life, and we can certainly put fillings in and take teeth out, but that's really it's not stopping the problem, and it's only generating other problems later down the track. The other way to go, of course, is prevention, and that's it's a much more efficient and much more pleasant way to go. And we can do this over a range of interventions and different approaches. So if we look at this is the epidemiological triad, and there is this really frames the way that we can look at preventing oral disease. We can bolster up the tooth surface, make it stronger, and we can do that through the use of fluorides, and we can do that on an individual basis at chairside, but we can also do it on a population level with community fluoridation, and I'll talk about that a little bit later. We need to get rid of the bacteria, and the only way we can do that is to get in there with a toothbrush and floss and clean. And of course diet, we don't want to feed the bacteria, and there are several ways we can do that individually with nutrition, education and instruction, but we can also do it at a population level, and I'm going to talk about that shortly. So if we're thinking about oral health promotion and thinking back to the relationship that we're wanting to try and put that head back on the snowman, integrating oral health promotion strategies into those strategies that are promoting general health and reducing inequalities is really the best way to go about doing that. And there are several ways we can do that. One is to look at a common risk factor approach. All the risk factors for chronic disease tend to be the same. They're very common to all of the chronic diseases, and the same for social determinants. And we know that dental caries is so associated with socioeconomic status. We really need to think about the social determinants, and that's things like welfare, education, occupation, all of housing. All of those things will have an impact on oral health. Obviously, a population approach is going to be much more effective and efficient than a high-risk prevention approach, but we do need both. And looking at an intersectoral multi-level approach, so across the health sector, so like we're doing today between dentists and doctors and other members of the health sector, but also beyond the health sector, and thinking about education and other health promoters and other people who work with children. So as the New Zealand Dental Association states in their position statement, that the emphasis needs to be placed on the promotion of good oral health and prevention of oral disease in a society and environment that supports good oral health. And this is, this goes for any chronic disease, and looking at chronic risk factor approaches, that we really need to have supportive environments to support the individual approaches that we do with education and nutrition and oral hygiene. There's a huge behavioural component to the promotion and prevention of oral disease. So we really need to have an environment that supports those actions. The World Health Organization has developed a list of priority action areas for global public oral health. And diet and nutrition is one, of course, and fluoride, and those are the two that we're concentrating on today. But clearly tobacco has huge synergies with oral health, and so any tobacco strategies that are used will certainly influence oral health. Health promoting schools, of course, in terms of education. I've spoken a little bit about integrating oral health into general health strategies. Kathy's going to talk a little bit about oral health systems in New Zealand. HIV/AIDS really is probably not so as much of an impact in New Zealand as it is in developing countries, but certainly monitoring and surveillance and research is really important in New Zealand as well. So this is where my interest lies here with food environment and what we can do about the food environment to improve oral health. And this is a diagram of the causal pathways between the dietary factors and chronic conditions. And we can see where sugar sits on the left-hand side of this diagram. And we can see that the influence that the dietary factors have on chronic disease through overweight, obesity, insulin resistance, and then through to the development of those chronic diseases. But there's also interaction within those chronic conditions as well with oral health. So if we think back to cancer treatments, increases the risk of dental decay, stroke impacts upon the ability to be able to clean your teeth, certainly, again, osteoporosis. And we know that type 2 diabetes has a huge association with gum disease. So it's really a complex web of interactions, as we know, and it's not really just the one thing. And so anything that we can do to impact upon those dietary factors will have huge implications, not only for oral health, but general health as well. The obesogenic environment, in my mind, is also cariogenic, just because of that common risk factor. And, you know, this is what we're up against. We're trying to promote and trying to find supportive environments for our children and also for the education that we provide. But this is what we have to fight against. And I have to say it's a huge frustration of mine from clinical practice that I would be teaching and trying to instill in a 12-year-old child that they don't need to be drinking Coca-Cola because it's really causing their tooth decay, and yet Coca-Cola is out there within an arm's reach of desire. And you kind of sit there and you think, well, you know, what can I do as an individual against this huge behemoth that's out there? So this is the current environment that we have. But strategies that can be used to help to improve this environment can also impact upon oral health, and oral health strategies can be implemented with those. My research, my PhD research, is looking at the food environment and its association with sport. And the parents, I've spoken to children and parents, and they've taken plenty of photographs of their food environment. And they too find the same frustration. You know, it's kind of difficult because you're up against the advertising constantly. A lot of it's contradicting what you're trying to teach them, and that's exactly how I felt in private practice as well. It's a battle, actually, and when you look at that environment that we're having to live in and cope with, it is a battle. This slide comes courtesy of my colleague Gabriel Jenkin, who has done a lot of work around obesity, food policy and politics. But I think, you know, we could also change the heading and say, well, this is, you know, policy and politics and oral health as well. And I think this is a fabulous slide. On the left-hand side, Gabriel's highlighted some of the strategies that are used in public health to be able to improve the environment, and one, of course, is food marketing, and thinking about banning and restrictions on food marketing, and not just TV advertising. You know, there's all kinds of things out there now. Gabrielle's doing some work on social media, so with Facebook and also internet advertising. It's just ubiquitous, it's everywhere. Food labelling, traffic light labelling would be great for oral health. You know, sugar and red, I mean, that's pretty simple. Although I sometimes wonder if Coca-Cola haven't already beaten us to the game. Healthy food policies in schools we did have and don't have now, but hope to have again. And that would certainly support any kind of oral health promotion. Food composition, so regulating the composition of sugar in products. Other things that we can look at, of course, are soda taxes, sugar taxes, pricing of healthy foods, accessibility of water. We're looking at doing some work around water fountains and trying to improve the accessibility of water in the community, and especially for children. And as Gabrielle points out on this poster and slide as well, that there are strategies that are used by industry to influence policy. And so we have to think about that really broad, big picture political view, and how that policy and how politics constructs our environment. So what we want really is something that looks more like this. These are a couple of pictures I've taken of water fountains that we have around the city, and healthy food and healthy things to drink for kids. And this is really what I would consider an oral health promotion looking environment. And it's certainly endorsed by the Global Strategy on Diet, Physical Activity and Health, which also mentions oral disease. So what's the role of the child health professional in all of this? Child health professionals certainly have a role to play in health promotion. And one way that child health professionals can do that is just a simple screening exercise. And this is Lift the Lip. It's a Ministry of Health, New Zealand Dental Association endorsed screening. It's really, really simple. Literally lift the lip, and it can be done by anybody: parents, nurses, dietitians, nutritionists, doctors. And it's really, lift the lip, have a look, see what's happening, and then make the appropriate referral if necessary. It's part of the before school check, and it's part of the Well Child program. Child health professionals also have a great opportunity to provide some oral hygiene and nutrition instruction and education to their patients, and to raise awareness not only with parents but also with other people, and do some advocacy work in terms of promoting oral health in other arenas. For hospital and DHB medical professionals, it's important to understand these problems and know how to deal with them in terms of service planning and prioritisation, and certainly the prevention of avoidable admissions into hospital. And also just to continue to collaborate with oral health colleagues within the hospital and also out in general practice. But I also think we need to improve the knowledge of medical professionals. I collared a couple of the fifth year medical students in the lift the other day and asked them how much they get in their curriculum, and they get a whole hour of oral health understanding and education. So, it just needs to be lifted a bit of a level just to give better competence and confidence in being able to provide these messages. But I also think the oral health profession has a role to play in continuing to keep oral health on the agenda and continue to collaborate with other people, not not our medical colleagues, but also across other sectors. And I think dentists need to kind of sometimes get their head out of the mouth a little bit and just think a little bit broader about the approaches to oral public health and oral health promotion, and think about the wider issues, including the social determinants of health. There's also a role here for nutritionists, teachers, health promoters, NGOs, sports people, role models, all kinds of people out in the community who can do some oral health promotion. I just want to finish up momentarily and just talk to you a little bit about fluoride. Completely different tack altogether. Fluoride has 3 actions, and it basically it strengthens the tooth enamel. Sounds like a TV ad that I once heard. But when it's ingested as a child, it gets incorporated into the enamel tooth structure and strengthens that tooth structure against acid attack effectively. It can also be used topically to repair early decay, and that's throughout life. So the benefits of fluoride and water fluoridation particularly are lifelong. It starts right from child as soon as their teeth are through, right through to our very last day actually. And fluoride also has an impact on bacterial growth and reduces bacterial growth, so it does have some effect on that bacterial interface. It can be delivered in a number of ways. It can be delivered individually at chairside through the use of gels, varnishes, foams, of course fluoridated toothpaste, which is recommended by the Ministry of Health twice a day, and also through mouth rinses. But we can have a much broader population approach through community water fluoridation Emmeline is going to talk about the challenges of water fluoridation and the role of the Fluoride Information Service in New Zealand a little bit later. So I'm going to pass to my colleague Kathy now to talk to you about the view from the chair side.
Thank you for having me here. It's a pleasure to be here. What I want to talk about is just to give more of a clinical perspective of oral health in New Zealand, in our region. So what I'm going to talk about, I've just split it up into 3 bits. I'll just give a bit of a background overview of the regional service that we provide and some Caries data that we get from that service, and what we do in the clinic for early childhood caries, and what the impact of poor child oral health is. And I think it is overlapping with what Maura has said, which is quite good. She's sort of prepared you a little bit. So this is not in any way completely the whole story, but it was just a very simple way of doing it. So the regional dental service is the Hutt Valley DHB has the contract to provide the service to the whole of Hutt Valley and Cape Coast, and that has been rebranded as the Be Healthy Dental Clinic, and you've probably all seen the vans that go around with the Be Healthy logo on them. So most children in New Zealand, 95% of school-aged children are enrolled with the school dental service or the regional dental services around the country, and so most children, when they go there, they have a checkup, and their treatment is completed by the dental therapist, and they are given a recall based on their risk, their future risk of caries. And if for some reason a child can't be treated by a dental therapist, then they might be referred to a contracting dentist for, say, extraction of permanent teeth or enamel hyperplasia, or things that are out of the scope of the therapist, or they might be referred to the hospital if there's a huge amount of work to do, the child is too young to have dental treatment in the chair, or the child has some sort of dental anomaly or special needs. And in that case, we would do if we can, we'll do the complete dental treatment and then refer them back to the therapist for their continuing care over their school age lifetime. So the 95% of New Zealand school children are enrolled with the regional dental service. Unfortunately, not quite as many preschool children are enrolled, and that's a huge problem that's being addressed at the moment. Often children their first visit with the regional dental services when they start school, so that's the first time that we can actually get in contact with a lot of children, because they're at school, the buses go around all the schools and do the checkups, and so the children that are not getting enrolled, a lot of them are in the preschool age. From the regional dental service, we have routinely collected data, and so this is just a little bit. So in 2012, 4,000 5-year-olds were examined, and of them, I've just turned it round. We usually report in Caries free, but I've just turned it round because I find it easier to sort of understand. But so 29% of children had one or more teeth with caries. So they had caries. Yes or no, how much they had isn't sort of captured in this data, but that is for everybody. For Maori, 49% of children, 5-year-olds, had caries, and for Pacific, nearly 60%. So there's a huge disparity in the prevalence of caries. The other way that caries is presented is in severity. So Maura mentioned the DMF index, and she presented it with capital letters, and that's for the permanent dentition. For primary dentition or deciduous dentition, it's presented with small letters. And so at 5, children don't have any permanent teeth. So we just measure the deciduous dentition. And so for everyone, this is a percentage. The mean DMF is a measure of past experience of caries and its severity. So for all 5-year-olds in the region, the mean DMF was 1.1, so that's 1.1 decayed, missing or filled teeth. And for Maori it was twice that, for Pacific it was more than twice that, and for other, which is European, Asian and other, it was way less. So I just to put it a sort of a slightly different way, the yellow one is the 5-year-old data of the prevalence data for Maori, Pacific and other. But these cohorts, so the blue one is the same cohort at 3, so the 2010 data. And so there's just a progression. Maori children start off they don't start off, but at 3 they've already got more caries. Pacific children have already got more caries at 3, and it just gets bigger. And it stands to reason. It's always, the DMF is always going to get bigger in every population, even if you're low risk. But it's just sort of a different way of displaying it. And the other thing that we talk about is deprivation, and it's the same thing. So this is the NZ dep to 2006, but it's just been recoded into quintiles, and it just, so low deprivation, there's way less, a lower percentage of the people who in areas of low deprivation have caries than the people in areas of high deprivation. And I guess that whole, is it ethnicity or is it deprivation? They sort of, this is just, it's a different deprivation measure. It's a school decile measure, but the areas, the low deprivation areas have less Maori and Pacific Island people represented in those areas, and so you sort of get a similar progression of experience. So the next thing I wanted to talk about was clinical care. So what I do as a clinician, so I've sort of got my sort of thing that I'm passionate about is prevention and public health dentistry, but the other thing that makes me happy is treating children and special needs patients. And so this is sort of a few things that we see on a day-to-day basis, that not all the children that we see at the hospital have caries. They might be referred, not necessarily by the therapist, but by paediatricians, by public health nurses, by the Plunkett nurses. They might be referred for a various number of reasons, not just caries. So we might see someone with special needs or an unusual dental anomaly. The one on the top right, left, right is someone with ectodermal dysplasia, and she's actually got no caries, but she's going to have some more issues with, when she's a bit older, she might get teased at school, or she might have some self-confidence issues that we'll need to deal with, so it's not so much caries. So there's other stuff that we deal with in a hospital dental department apart from caries. The one on the top right is that child only has one hole in their lower teeth, but the problem is that child is about 2.5, and so there's no way in most cases that that child's going to lie down in the chair and have an injection and have just a standard filling, and so sometimes they get referred just because we can't really leave it, and we need to do something, but it might not be able to be done in the regional dental service, just for cooperation reasons and age reasons. The one on the lower right that's what a dental abscess often presents at, so infection, pain or infection, and this is often what we see when someone comes in pain, is there might be a little abscessy thing on the side of the tooth with the caries. And the one on the lower right is just early childhood caries, which we see a lot of, which I'm going to talk about now. So the American Academy of Pediatric Dentistry just that this is their definition of early childhood caries. So the presence of one or more decayed, missing or filled teeth, which we know what that means now, in any primary tooth in a child 71 months or younger, so that's just under 6, and severe early childhood caries. There's lots of definitions for each age, but it starts at age 3, it's a DMF of 4 or more carious lesions. And if you were to lift the lip, if you were to look at a child's dentition and see this, that is just classic early childhood, severe early childhood caries. So what we know about early childhood caries is that it's one of the most common chronic infections of childhood, and there's lots of causal factors. We've talked about them already, the oral health related behaviours like diet and oral hygiene. With diet, it's not just eating sugary foods, it's also eating habits. So a child who grazes constantly is more likely to be at risk of caries than someone who just eats 3 meals a day. Deprivation and ethnicity have got a really strong correlation with early childhood caries and their rates. And if a child has had early childhood caries, they are much more likely to get more childhood caries. So even if we treat it, they are still at risk of getting more, and that's something that needs to be addressed more with prevention. And it's a really strong predictor for adult caries, as Moira said. So the thing about early childhood caries is it wasn't always there, and it is really, really preventable. And so the first sign of it, this is not a perfectly fine dentition. There's just some, it's not working. Where the little arrows are, there's little white spot lesions. It just looks like a little shiny spot. But in the mouth, it's an opaque sort of white spot. And that's an indicator of the beginning of early childhood caries. And that is when we want to see children to start this sort of preventive story to stop them getting more caries. The problem is that we often, with that because there's a low uptake in preschool children, we don't often get to see these children, and the regional dental service don't get to see them as much as we want, because there's only 50% of them are enrolled. And so this is when we want to see children, so that we can start preventing decay so that it just doesn't get worse. And so it's a little bit more obvious, but it's kind of a bit late for some of these teeth, and the chances are that the back teeth will have started to be affected as well. And then it gets to a point, the throat pecks in, this child's having a general anaesthetic for dental treatment, and they're going to lose those front teeth and likely some back teeth as well. What we want is we want to get to this point as little as possible. So the current trends in treatment, there's a movement away from restorative care, and that's where the public health side comes into it, is we don't want the children to get caries in the first place, or we want to stop it really early so that we can reverse it rather than have to do major treatment on them. So we want to detect it early, we want to prevent it getting any worse, and referral if necessary. So, and even if a child does have huge amounts of caries and they've either had or haven't had treatment, they still need a really strong preventive care program in place. And if they're really young, unfortunately, they might need to go to the hospital and have the dental treatment done under general anaesthetic. So one of the things that I do at Heart Hospital and the dentists and dental departments do is they do dental treatment under general anaesthetic. And so I've just split it into two. So acute, the reason why you do an acute GA would be because a child's got a facial swelling or they're in pain. And if it was planned, it's usually because of lack of cooperation. They won't let you do the treatment in the chair, maybe because of their age, or because there's just so much to do that you just can't expect a 5-year-old child to sit in the chair for 4 one-hour appointments. The waiting list at Heart is about 4 or 5 months. So some of the reasons why we would whip them in really quickly on an acute list is if they've got facial swelling or acute pain, that we can always just give them antibiotics, IV or oral, but the speediest way and most effective way of dealing with that infection is to just get the tooth out if it's a tooth that's causing the infection. So the reason I want to talk about GA is not so much about the treatment we do under GA, but just the fact that this is the worst. What we see on the children that we need to treat under GA is the worst there is in 5-year-olds. And so this child is about 4 or 5, and they will lose those back teeth. And those back teeth are supposed to stay there until they're between 9 and 13 years old. So they're going to have a long time with no back teeth. So there's a huge impact from early childhood caries. Something like 50% of children with early childhood caries report some pain or have some infection. It affects their physical appearance, and it can affect their self-esteem, it can affect their oral health related quality of life. It has a huge economic cost, so a general anaesthetic for dental care just by itself costs about $3,000. On top of that is the medications that they need, their visit to the school dental therapist, the general dental practitioner, and then the hospital. It can cause impaired growth and nutrition. I actually like Maura's picture better than my list. Time off school, loss of sleep, and it's a huge predictor of future caries. So children with early childhood caries are 3 times more likely to have caries in their permanent teeth. So what I've been talking about is the stuff down the bottom, the ambulance at the bottom of the cliff, and the midstream stuff. And I guess that's where we want to be. We want to be upstream and midstream, so that we don't have as many children who need general anaesthetic and major dental treatment, so that we can spend more money on helping the ones who, that group that will probably always have caries. So, yeah, Maura's talked about the upstream measures. We can make changes at all levels, and the individual measures are mostly the oral health education, early intervention, prevention, and treatment is not prevention, it's just fixing stuff that we can't actually go back and change. So I would just encourage you to lift the lip and have a look. Thank you.
So I've got me again now just for a couple of slides. I just want to talk very briefly about community water fluoridation. There's been evidence around now since the 1930s and 40s about the benefits of community water fluoridation, and the New Zealand water supply has been fluoridated since 1954. It's been described as one of the 10 most important public health measures of the 20th century, and I think it actually probably counts in the top 5, if not the top 3. Fluoride is a naturally occurring element, and when I worked in Rotorua for 2 years when I graduated, and some of the water supply in one part of the city there is actually naturally fluoridated at conveniently 0.7 parts per million, which is the recommended dose. And you know, you could tell which side of town the kids came from just because of their address often. Currently in New Zealand, just over half of the population have access to reticulated fluoridated water supply, which means again that 50% don't, so who are at risk of getting dental caries or have a higher risk of dental caries. The benefits of fluoridation of the water supply go above and beyond other fluoride sources. So there are benefits to each fluoride source, so say toothpaste for instance, but also if you add in community water fluoridation, you get extra benefit from that. Community water fluoridation certainly reduces oral health inequalities, but unfortunately for Māori, the lack of fluoride mediates the inequalities, because many Māori live in areas that do not have community fluoridation, or they do not have access to reticulated water. So just looking at those disparities, these are figures from actually the Ministry of Health, their oral health data set that they keep, and these are children 2 to 14, and this is a combined DMF of both primary and secondary teeth, and we can see that the DMF, the mean DMF is 1.5 for children in a fluoridated area, and it's 2.4 in non-fluoridated areas. And then if we look at the table here, you can see in terms of the proportion of Māori who are caries-free in a fluoridated area is 40%, which, as we can see, is lower than the total population. But then if we look at the non-fluoridated areas, that drops down to only a quarter of Māori who are caries-free. And then equally, the DMFT rises from 2.9. up to 4.2. So that gives you a clear indication of the benefits of water fluoridation. There are some risks in terms of fluoridation, and this is a picture of dental fluorosis. About 10 to 25% of Australian and New Zealand children are affected by this very mild fluorosis. And the Food Standards of Australia and New Zealand did a risk analysis and found that for most people this form of fluorosis wasn't really a concern. And if you think about the benefits of water fluoridation over particularly what Kathy's shown you, I think the risk is probably, the benefits outweigh the risks. But there are certainly challenges to community water fluoridation. So I'd like to introduce Emmeline now to come and talk to us. Emmeline's a registered nutritionist with over 13 years' experience in public health nutrition, including working as a community nutritionist for Ngāti Porou, Haurora on the East Cape. She's now currently the coordinator of the National Fluoridation Information Service based out at Regional Public Health in the Hut. And she's going to talk to you about the fluoridation service, and then she'd like to just open the floor to discussion.
Hello everybody. I only have 2 slides. I think I just want to start by explaining to you who we have in our consortium. So we have a number of partners who are our experts in various areas related to community water fluoridation that we can call on, and they provide for us peer review and review of the scientific literature. So Barry Borman and at Massey University, Centre for Public Health Research, he is the key person that does our ongoing 6-monthly literature reviews. And we have Dr. Chris Noakes. I'm not sure if many of you know of him, but he works for ESR and is extremely knowledgeable in everything to do with water. He's a water chemist. And we have Dr. Neil Stevens from the Hutt Valley Dental Community Dental Service, who is head of department there. And we have Dr. Robin Wyman, who is has been many various things, but now is the head of department at Hawke's Bay Community Dental. And we have Dr. Michael Beasley, so he's one of the toxicologists at National Poison Centre based at Otago University. And then Kathy over here, she's our comms coordinator, and I'm the runaround person, I'm the national coordinator. So, following on from what Kathy and Moira have said, I guess it's fair to say Dr. Robin Hazeman-Welsh, who's the Chief Dental Officer for the Ministry, wanted to be here today, but she had to be elsewhere. But she would say that water fluoridation continues to be a very important part of the Ministry's oral health policy for several reasons, the main being that there's very unlikely to be new money for oral health anytime soon. And so prevention is still very much key for them. And as far as the research goes, so far, there isn't a more effective population-wide or cost-effective intervention that can be done. So, Ministry decided they needed a national fluoridation information service, and the reasons they decided they wanted to have this service as a national group and independent to themselves is they wanted to be able to monitor, they wanted to have an independent group that was monitoring and advising on the ongoing research, both nationally and internationally, around community water fluoridation. And because community water fluoridation tends to be quite a contentious issue, and many, if not all, health issues that you can think up tend to be related to it at one stage or other, they wanted to be able to have an independent group that could look at the science and then provide robust advice about whether or not the assertions that happen to be currently circulating had any scientific validity. So how do we do this? So we have a website, and we publish on our website everything we do. And I've brought for you today, if you're interested, some handouts. So we have in the handouts for today, we do a e-newsletter. The e-newsletter is particularly aimed at counsellors. Counsellors tend to be very much bombarded with a wide range of information and misinformation, and a lot of it's confusing, and a lot of it is presented in pseudo-scientific or cut and paste bits of science, which are often very difficult for them to follow. And so this document is aimed at giving information directly to them, small pieces of information, plain English, taking out the jargon. We also have in these little handouts, I've got for you the key finding page from each of our scientific reviews. So there's 5 scientific reviews that we've done so far. The first one was a 10-year review of reviews on water fluoridation internationally, and then we've done 4 6-monthly reviews since then. And so that's just got the key findings there for you to look at. And we provide those key findings obviously on our website to everybody, but also for the ministry. So we include implications for the ministry's policy and whether or not the science is saying that the continuation of policy as it currently stands is a good idea in terms of science, or whether there's something new that they need to look at and need to consider. So that's sort of in a nutshell what we do. We work by answering the phone a lot. We have a lot of telephone calls from medical officers of health and registrars and health promoters around the country. I like to call them fluoride emergencies because people tend to never call until they need to present to the council or answer a letter to the editor that day. So we tend to always be running. And usually they are contacting us quite likely in a reactionary way. There's actually the New Zealand Fluoride Information Service. Moira is not us.
Oh, sorry.
The New Zealand Fluoride Information Service is an offshoot of the Fluoride Action Network New Zealand, who set up about a week after we started so that they could provide independent, robust advice about water fluoridation in New Zealand. So principally we work with the ministry, and we deliver to DHBs, but also to councils if they come directly to us, but very often to DHBs as they're working with councils and as an issue being brought up in an area, trying to work out what's the issue, what's the real concern, and how can we answer that for people. And all of that information we put on the web, and anything that we have on our web, we are very happy for people to use it, to print it out. Anything can be shared, and I guess our approach there is that we have an ongoing stream of Official Information Act requests of various kinds, and so our approach is to be as transparent as possible with everything we do, so that it's not secret information, it's all publicly available. Anyway, I thought that, I don't know how much the audience is aware of the contentiousness of community water fluoridation, or quite where it's at in New Zealand at the moment, but I thought I'd just open up for questions because that might be the easiest way to get some discussion going.
Do we have any questions?
So it's the 52% of the population is fluoridated water. Is that percentage going up or down?
It's pretty static. It's gone up very slightly. The problem at the moment is that, in terms of a population health intervention, is that the science shows that the cost effectiveness happens when you've got a large population coverage, and when you've got a smaller water supply and smaller populations, the effectiveness of putting in a plant and continuing to look after it, the cost benefit drops. And we have lost it in one large community so far, and we've gained it in 3 smaller communities. So there's sort of an offset there, but yeah, so it's pretty static. But this year will be this year that we're in now. There's some big decisions happening around the country, so by the end of this year it could be markedly less than 50%.
In light of the pressure that's placed on local government and the limited resourcing they often have, and particularly the recent referendums that have been going on around water fluoridation, do you see any potential for the jurisdiction to be taken away from local government to a central government position?
That question was asked also by the medical officers of health at one of their national meetings, and Fran McGar's response was, not on this watch. So I think it's fair to say that with the current legislation, there's no interest in the current government to review it or change it, and certainly they're very shy from anything that could be perceived to be unpopular. And I think the thing about community water fluoridation for both local and central government, what continues to be a problem, it's very difficult to work out from the few people that are noisy and persistent and lobby continually, how much that actually reflects the general population and what the actual feeling about community water fluoridation, how useful it is, actually is in the general population.
Any more questions? Thank you for that. Do you think there's any room for a more collective, consolidated Māori viewpoint and Pacific viewpoint on this issue, given that in the fragmented way we presently operate, it is really difficult to attain much of a pro-fluoridation view in the Council's water ministry. But given that Māori and Pacific have, in some sense, a stronger interest in this than other sectors of the population, given the greater effects on inequalities, has there been any appetite or work directed towards a really sustained collective, this is something that affects us kind of viewpoint, which might carry more weight?
Te Marama, the Māori Dental Association, is very clear on their position, and they very much have that kind of stance that you're talking about, and that's what they talk with their members. I think in the areas that are looking at referendum later on in this year, there's been some quite concerted lobbying into the communities, directly to Marae and Kaumatua from the anti-fluoridationist group, to try and suggest that community water fluoridation is against paunga and is sort of anti the sacredness of water. That's been effectual in some areas. It depends. With Māori dentists who've worked in the field, that tends to be deeply annoying. And so next week, for example, in Hamilton, we were having a large tribunal, Hamilton City Council, we've got 2 Māori dentists who are going to do considerable discussion about that. One of them is the current head of the Te Marama, and one of them is Albert Kiwini. I don't know if you're aware of him, but he's worked as a Māori dentist for a very long time. He's retired now. And his presentation is very much around actually people, let's get real with what we really see here and what's going on for us.
Do you know if there's been any research at all into attitudes of Māori and or Pacific into this? Because now that issues about Māori attitudes and that fluoridation is not, fluoride is not natural, that kind of thing.
I think I think that's been portrayed in letters to the editor. I don't think that that's fair to say that's a widespread view.
I'm not suggesting it is,
yeah.
But because that claim is being made, it would be useful, it would seem, to sort of say, well, this isn't actually, or a sort of a more scholarly discussion perhaps of whether or not it is consistent with Māori tradition and whether or not it is or not consistent with Māori attitudes, whether or not some, as I say, sort of more widespread viewpoint be gathered on that subject, rather than having people in Fluoride Action sort of basically making use of that particular cultural claim, which may or may not have any merit whatsoever.
Whether something's happening on a community level, I'm not aware of. We did do some work with ESR to put together a funding application to the HRC to do a widespread piece of research around attitudes, which included ethnic groups.
Yeah.
The response that we got from HRC is similar to the response we've had when we've looked at other research in this area, which is that water fluoridation is not a research priority in New Zealand. That it's difficult for them to prioritise research on something which there is a vast amount of international literature on, and which, from a scientific point of view, is very clear over other things that need to be researched. For example, I think they put in their response to us SIDS, that's the kind of question that they're weighing up. So although they felt we had provided a very compelling argument and had a really interesting a research proposal, they couldn't prioritise water fluoridation over other health issues.
Except that there wouldn't be any great international evidence whatsoever on Māori values and attitudes, because that's not an international thing.
No, there is a little bit on Indigenous attitudes.
Indigenous,
yeah. But that's still there. Obviously we put that in our proposal, but that's their position on that.
Do you have a sense of which particular bits of anti-fluoridation misinformation have the most sway with counsellors?
I think what seems to ultimately have the most sway, and ultimately this comes down to counsellors to have to decide, is whether they think that individual choice for their ratepayers and for people that they feel that they represent is a more important issue and is more correct, if you like, than taking a population stance and doing a population intervention. I think a lot of what the counsellors do, and it's interesting the feedback we get from them after these tribunals and referendums when they've sort of thought about things a bit more, is they don't necessarily recognise that they do other population measures, such as taking away the rubbish or being in charge of the sewage or the local roads. And on reflection, they'll come back and say those kinds of things to us. But certainly in that kind of environment and in a controlled, sort of presentation environment, I think they often find the argument of individual choice quite compelling.
I think we should probably move on to the group discussion now. Would Moira and Kate like to join Emmeline over? Okay, we have a question from Michael.
I just think, sort of speakers, I thought that was absolutely fascinating. And you've got such a, even though we think that the oral health is a microcosm, you've got really every public health issue that you've really traversed today. One of the things that's very interesting is this, we've often got this paradigm of the infectious disease and the non-communicable disease as though they're separate universes. And I think you've shown how they really overlap so intensely in the area of oral health. And I know some of the strategies you've talked about are really NCD type strategies of looking at the mesogenic environment and so on. But I'm just wondering if you viewed dental caries as an infectious disease, which they are as well, will that change the way we approached it, do you think? I mean, it's not obviously going to be a notifiable disease because that would be a lot, but just the ideas of reducing vertical transmission from mothers or parents to young children, and horizontal transmission in households, and all the things that might entail. And I guess I'm sure there's work on vaccines, and I know products like Bliss, for instance, the probiotic that changes the oral microbiome has been shown to reduce dental caries. But I'm just wondering, do you think there is room or advantages in thinking of this more as a contagious disease? Would that help at all?
Yeah, it's that's part of our sort of preventive approach is to slow down or prevent the maternal transmission from mother to child, because that's when a child is born, they don't have strep mutans in their oral cavity. They get it from somewhere, so it is a bacteria that they get from somebody else, and that is part of the sort of prevention thing. If we can slow it, they are going to get that bacteria in their oral cavity. But if we can slow it down and stop them getting it till they're a bit older, then they won't get caries till they're a bit older, and hopefully the decay won't be as bad, and they'll get through their childhood without losing any teeth or getting early childhood caries. So that's part of the whole picture, definitely. The problem is that the people that we look, there's a huge amount of people with no caries in New Zealand or very little caries, but the ones who have this incredible sort of severity, I don't know that that's not the thing that's going to stop it happening.
We had that conversation as the consortium about whether or not that would be a useful piece of information, particularly for counsellors, when you're thinking about their population and how they serve their population. And essentially came to the conclusion that that would get a huge amount of outrage from anti-fluoridationists, that although it's true, it's not something that you could easily explain.
And two, also, I mean, how do you actually eradicate bacteria? It's a bit of a chicken and egg thing too, isn't it? You've got to try and get rid of the bacteria to not transfer it. It's, that's kind of, and then thinking about immunisation, I mean, it's up there with fluoridation in terms of the strength of anti-immunisation. So, it's certainly an area I think that's been explored and do try and work preventively to try and prevent that transmission. But yeah, that's an interesting report.
Just a question for Kathy. The Lift the Lip screen is part of the Well Child program, so all children need to, access the Well Child contacts, which they have about 8 before they reach school age. Have you noticed a change in referral patterns from that? Because that seems such a great opportunity to identify Caries early, so that you can have increased referrals. Have you noticed any changes?
Well, I haven't myself, because I haven't always worked, I haven't always worked in a hospital. But yeah, we get a lot. We get quite a few referrals from Plunkett, where they do the Lift the Lip check and they see Caries and they refer. So I guess it has, I definitely think it has increased the number of referrals of children. I guess the problem is that they're often children who have got terrible. I guess the great thing is that they then get registered, they get enrolled in the school dental service, but that's often too late for those children anyway, as far as their treatment needs. So yeah, it definitely increased the number of referrals. It's just sort of getting them earlier.
Rich?
You mentioned about the effectiveness of the anti-fluoridationists and getting this relitigated and so on. What about the effectiveness of the pro-fluoridationists and dental professionals and other groups who may be lobbying in favour and getting to councillors and trying to get it in the 48% which isn't fluoridated and getting it on the agenda there?
Just community people who are pro-fluoridationists, there's quite a few. Limited number. They tend to be retired dentists, and they tend to be very busy, and they tend to make themselves very active. The dental profession as a whole, I'd say, is rather disconnected with the community fluoridation debate. There's a few dentists who are part of the anti-fluoridation group who consider that there hasn't been enough, I guess I haven't read it, but there hasn't been enough research looking at other potential health effects from fluoride other than just on teeth. The medical office of health and the public health units tend to do an amazing job, and each one of these council meetings, so for example, next week I'm going up to Hamilton. I personally have put into that probably well over 100 hours of work, and we've got Pat Tilly from the Ministry of Health, we've got Dr. Hayes and Welsh, we've got a couple of consortium partners, they've got all the CEO, the medical officer of health, the principal dental officer, the public health registrars, and they have that team up there, they've put in hundreds and hundreds of hours. And although it's in service specifications, it is inevitably taken away from other hours. It's taken away from whether that's clinical or whether that's public health issues. So there's not a huge, for example, with the Tamaraki DHB last year, after their event, they did a little bit of an add-up, wrote a letter to the ministry to try and point out just how expensive it is in terms of hours to put in. So mostly people who have it in their service specifications to do this work tend to avoid it unless, as I said, it becomes an emergency.
My question might include Sue as well, but what policy or what innovations have been put in place or intended to be put in place to tackle Māori and Pacific disparities? So,
thank you. There has been a number of things. One of the key issues that was presented from those community groups, culture groups, was the workforce mix, particularly a lack of Maori oral health workers and Pacific oral health workers. And so there's been a real drive in the last few years to foster and engage participation in the oral health programs at the University of Otago and AUT for Pacific students, and those numbers have certainly increased. So we're starting to see an increased pool of oral health graduates, 50% Maori and Pacific families. The other thing that has been happening in District Health Board land is, as you probably know, there's been significant investment in child and adolescent oral health services. And as part of that investment, there has been a change in the workforce mix, which has included the engagement of more dental assistants and kōwhina in some places to support service delivery. So we're seeing in that workforce mix at the HB lead a greater pool of Maori and Pacific oral health personnel, which is encouraging. In terms of I'll go back to your question and Kathy's response and just give you some updated information. At the end of last year, 70% of preschoolers across New Zealand were engaged in the service. It is much less in the Wellington region currently. And I'm pleased to say that it's still not good, but 54% of Maori were engaged in the service and 66% of Pacific children. But there lies a continuing challenge is how do we engage those families into the service. There's a significant increase in the number of children that are referred to the service from well child providers, from te Morikiura providers, from preschool centres, kahangareos, but there is currently still a disconnect from referral to actual utilisation, and we're seeing significant areas of families not attending their appointments, particularly for Maori and Pacific children. So looking at how we can support those families and what we need to do to encourage them to take the opportunity of engaging with services.
Do we have any more questions? I'd like to take the opportunity to thank our speakers for a really fascinating presentation on what's obviously a major public health issue as well as an issue for those working in the clinical area. So thank you.